Right, so let's kick off with a sedation overview then. And I guess the natural place to start is with a definition. Well, there are some different definitions that exist out there, but essentially, and how we're going to consider it in this course, is sedation is a pharmacological inducement of an altered level of consciousness. So sedation is frequently used both pre-hospitally and in hospital, and that explains the fantastically diverse on this course. Now, sedation can be used to facilitate life and limb-saving procedures, allowing them to be performed in what otherwise would be a completely intolerable manner, down to the more nuanced type of sedation which can just make a procedure that much more pleasant and a much better experience for the patient. Now, obviously, when you think about those two ends of the spectrum, then there is going to be a range of the depth of sedation that can be achieved. And when you think about sedation and that pharmacological inducement of an altered level of consciousness, that runs all the way between a fully conscious patient down to the far, far end of the spectrum to just up and to, but not including, general anaesthesia. Sedation involves the following aspects to a greater or lesser extent, depending upon the strategy and agents that are used. But that includes analgesia, sedation, and amnesia. And in some cases, it will also involve some anxiolysis. Now, the only sedative agent that can provide all of these is ketamine. And therefore, a short-acting analgesic is often used in combination with a sedative agent to achieve all of these aspects. And we're going to go into this in a lot more detail in the pharmacology section of the course. Now, when we try and describe the levels to which a patient is sedated, this is, I think, really difficult to get a good grasp of the depth that the patient is either in or that we are aiming to get them towards. But there are definitions, again, that exist out there, and these are sometimes useful when we're trying to really quantify those categories of sedation. And a good place to look is the American Society of Anesthesiologists, who use the following definitions for sedation, and they've been adopted by the Royal College of Emergency Medicine in their sedation document. And again, that provides a really good platform to go and have a look at to see some of the information that's available out there on sedation. So first up, you've got minimal sedation or anxiolysis. And this is really at the light end of the scale of sedation, and it's a drug-induced state in which patients respond normally to verbal commands. So they really are quite light. Although their cognitive function and coordination might be impaired, so it might be a bit delayed, ventilatory and cardiovascular functions are unaffected. And in the emergency department, certainly in the definition that exists at the moment, this is most often achieved using inhaled Entonox, which is 50% nitrous oxide and 50% oxygen. So that really is minimal sedation, the very light end of the scale of sedation, and as you might imagine, involves the least likelihood of complications to do with the actual sedation. Not necessarily the procedure, but to do with the sedation. Next up, we've got moderate sedation or analgesia, also referred to as conscious sedation. Now, this is a drug-induced depression of consciousness, during which patients respond purposefully to verbal commands, either alone or accompanied by light tactile stimulation. So you're talking about here getting a response from your patients, but actually the stimulus required to get that response is a bit greater. No interventions during this moderate sedation are actually required to maintain a patent airway, and spontaneous ventilation is adequate. Cardiovascular function is usually maintained, and in the emergency department, this is often achieved using a combination of opioids and benzodiazepines. Next up, in the American Society of Anesthesiologists definitions, is deep sedation. And this, as you might expect, is going down that continuum, so it's getting them deeper and deeper into their sedation, and also with that brings about a risk of some further complications associated with that sedation. So a drug-induced depression of consciousness during which patients cannot easily be roused, but respond purposefully following repeated or painful stimulation. The ability to independently maintain ventilatory function may be impaired. patients may require assistance in maintaining a patent airway, and spontaneous ventilation may be inadequate. But cardiovascular function is usually, not always, but usually maintained. Next in their definition is general anaesthesia. Now, this obviously isn't sedation that we're talking about here, but I guess it's the limit of sedation to show you that when you go to deep sedation, then the next level you're going to get to is general anaesthesia, which is not what we're looking to achieve here. But general anaesthesia is defined by this body as a drug-induced loss of consciousness during which patients are not rousable even by painful stimulation. The ability to independently maintain ventilatory function is often impaired. Patients often require assistance in maintaining a patent airway, and positive pressure ventilation may be required because of depressed spontaneous ventilation or drug-induced depression of neuromuscular function. Cardiovascular function may also be impaired. Okay, one last thing to add in, because that was quite a nice linear continuum of the definitions, is that to do with dissociative sedation. Because this is mentioned in the RChem document. And ketamine is a unique drug in sedation practice because it causes a dissociative state that does not fit with standard definitions of sedation that we've already listed. A separate sedation category, this dissociative sedation, has therefore been introduced. Dissociative sedation is defined as a trance-like cataleptic state characterized by profound analgesia and amnesia whilst retaining those protective airway reflexes, spontaneous respirations and cardiopulmonary stability. And we'll go into that state in more detail again when we go on to the specific pharmacological agents. So the key bit here with sedation is that procedural sedation can produce a variety of depths of sedation, allowing procedures to be tolerated or not unpleasant, whilst maintaining some cardiorespiratory function in a way that may not happen during an anaesthetic. And hopefully, having run through those different definitions, it's clear to see that this is a really broad-ranging state, this sedation, depending on the depth to which you go. We need to be aware that that's really useful and that we can titrate a patient's depth of sedation to the procedure that we're going to perform. But we also need to be aware that it's possible to have patients too lightly sedated, or also, in fact, it's possible to take them too deeply sedated. And with this comes extra risk of complications from that sedation.
Lovely stuff, Simon. Thanks ever so much. And that was a pretty short and punchy introduction to sedation. I didn't know you had it in you. Well, listen, I think it was almost a little too short and punchy because I got some questions for you, actually, if you don't mind. First up, I think you've described sedation really well, and it sounds like a fantastic procedure, really versatile. Clearly, a few bits and pieces we need to think about, and we're going to run through those as the day progresses. But if sedation is so wonderful, shouldn't we be just doing it more often? Why should we be thinking about this so much?
So, yeah, that's a very valid question. So,
Good.
I guess we've really got to consider, haven't we, the risks versus the benefits when we're talking about sedation, because practice has certainly moved on a fair amount in the last few years. And I think it's fair to say that there are several things that we would now sedate patients for, which we wouldn't have considered, 15, 20 years ago. But what we've got to be really careful of as well is making sure that we're not noticing that somebody needs a procedure to be done and then snapping straight into that, well, that's going to be done under sedation. We need to really remember that there are a variety of ways in which we can help give our patients the best experience through whatever difficulty they might be experiencing. So, for example, it's not uncommon that you'll sedate somebody for a shoulder relocation, but there are really simple things like good patient positioning, reassurance of a patient, decent analgesia, maybe even sometimes some regional blocks, so maybe an intra-articular block. So there are a number of different things which can achieve a good procedure that don't involve sedation. So first up, remember that there are other options. But we obviously wouldn't be here talking about sedation for a number of hours if we weren't significant advocates of it. So there is definitely a place for sedation to improve the ability for us to perform procedures on patients and also their experience. But being aware of the actual risks that sedation holds is of huge importance when we're deciding whether or not sedation is going to be part of that patient's experience. And Obviously, some procedures are going to absolutely require sedation. So things like a DC synchronized cardioversion, having sedation for that is going to be pretty much a must, apart from in the most extremist of circumstances. But as we say, when we've got things like musculoskeletal manipulations, popping a shoulder back in, we've got other options that we can consider. But there was a great systematic review and meta-analysis from Bololio, which I think was published in Academic Emergency Medicine a few years ago, and that looked at adverse events in adults undergoing procedural sedation, and I guess really enables us to get a feel for how likely it is that we'll get complications or adverse events that we don't want during sedation. Now, that included about 10,000 sedations, and they found that in those, hypoxia was actually a reasonably common complication at around 4%. So that's not an infrequent complication with that group of patients that were being experienced. Vomiting at around 1.6%, aspiration just a bit below that at 1.2%, getting down to those things that you really don't want to be experiencing, and we'll cover how to deal with later. So laryngospasm at 0.4% and intubation at 0.16%. So it isn't uncommon, certainly looking at some of the literature that exists out there, to see complications from sedations.
That's really interesting, Simon, and actually that can give us a really nice framework for thinking about how to prepare for these sedations. And I know later on today we're going to be discussing about preparation of equipment and the patient and thinking about those adverse events. So that's really useful to benchmark that against.
Absolutely. And there is other stuff out there. And again, we'll link to this in the show notes. So there was an audit from RChem, so the Royal College of Emergency Medicine, looking at procedural sedation in adults. And that was nearly 9,000 patients, 80% of whom are getting joint reductions. And there are some other interventions that are in there. And that showed an associated mortality rate of 0.1% when looking at procedural sedation. Now, again, that's really difficult to get a feel for. Is that these patients are presenting in extremis with other problems which are going to contribute towards their mortality, or is that a mortality associated with sedation? But I guess the bit that I think we should really take home and away from this is that sedation can be performed in a safe manner, and that's what this course is all about, but actually that there are risks associated with it. So we just need to make sure that we're picking the right patient for the right reason and performing it in the right way.
Nice one. Good. Nice comprehensive answer there, Simon. I didn't even barely get a word in edgeways.
Perfect.
Well, I'm going to get my moment now because, I'm already getting the feeling that this is a little more complicated than we'd initially kind of put forward. I was thinking this sounded like a great procedure that we should be doing on everybody. But this is starting to unravel already. And we're just starting to scratch the surface, aren't we? And there's loads more ahead for the rest of today. And we're hopefully going to end up with a really nice in-depth knowledge of all things sedation by the end of today. But I got one more question for now, which is, who can provide these sedations? Because you've already started to highlight that there are some risks involved here. So I'm assuming we can't just kind of, splash these sedation agents around just kind of willy-nilly. So who can provide it, and what training is required to enable us to competently undertake procedural sedation?
I think it's fair to say that by the end of this course, that doesn't mean that we're all going to be signed off to then go and deliver sedation. I'm sure nobody here would be thinking that at all. But what we're trying to provide here is a good level of clinical understanding of exactly what sedation involves, and give you some pointers towards some other documents and evidence that you might want to go out there and read. But each workforce, and I promise this isn't a fudge of an answer, each workforce and specialty groups essentially has a different way of being signed off for sedation practice. And, I think it's up to all of us to go away and make sure that within the system that we're working, that we're following that process and we're getting signed off for it, and we've got appropriate governance that surrounds it. But for example, RChem, so the Royal College of Emergency Medicine, I'm obviously biased by mentioning this because it's the college to which I'm attached to, but they've got some really sound recommendations for emergency medicine ACPs, so advanced clinical practitioners. And they say that you should have emergency airway skills up to but not including drug-assisted intubation, have a completed advanced life support course or equivalent, must have attended an approved educational program on safe sedation, must comply with local guidelines and policies, as you'd expect to do with procedural sedation, have a logbook of all sedations performed, including adverse events and outcomes, and must undergo yearly assessment or work-based place assessments on airway management skills. So yeah, what we're talking about here is that sedation should have a really good teaching package, which hopefully this can help form be the part of for many of you out there. But actually then the applying that knowledge to practice, that needs to be done under some really good supervision, and it needs to be something that we're constantly keeping up to date, making sure that the skills to do with not only delivering that sedation but dealing with the complications are up to date, and that we're spot on with delivering that care. And then that we're having a really good governance structure and reviewing our own complication rate, especially with regards to the evidence that we know that's out there, to try and really refine our practice. But I guess that's a good example from an in-hospital perspective, James. But what about from a pre-hospital perspective? Who is it that can then go on and perform sedation in the pre-hospital environment?
Yeah, interesting question. And again, I can only really speak from my experience down in the southwest. And really, when we're talking about sedation, that's just being delivered by specialist paramedics in critical care. So to undertake the training, I guess you naturally need to be a trainee specialist paramedic in critical care. And actually, there's a really nice package which sounds sort of similar, I guess, to the ARChem ACP program. And so we would start out by undertaking an initial theory and scenario-based training, and that's delivered by one of our consultants on the unit. And then once you've done that, there's then a written assessment, which basically just kind of assesses your fundamental understanding of all aspects of sedation and the knowledge that underpins it safely. You then move on to signing some PGDs, and interestingly, the Southwest has just moved to what I think is a really sensible plan. And there's actually some relatively restrictive PGDs for ketamine in particular, because I guess when we're thinking about pre-hospital sedation, this is really the agent that we're thinking about. So there's some restrictive PGDs that you then sign as a trainee, but then that allows you to operate autonomously within that pretty restricted area of practice. But that gets you experience and exposure to ketamine. And whilst you're doing that, you're maintaining a log of all of those cases. And then when you think that you have got to a level that you feel comfortable with, you can then submit that case series to a board, which consists of the medical director and various other people. And then you get signed off. And then you can kind of sign up to the next step up of PGD, which has a wider scope and allows you to get stuck into some slightly more interesting and challenging cases. Now, that's just down the analgesia pathway. There's also a sedation pathway, which you can only start once you've got experience of using ketamine in an analgesic capacity, which I think, again, is really sensible. And we're going to talk at length later on about the different agents. And all of them are very much an art form. You know, we're going to give you some boundaries of drug dosages within which, it's safe to practice. But actually within that, there's very different patient experiences and the way the patient will respond to individual doses. So you get your experience with ketamine analgesia, and then you move on to starting to observe some ketamine sedations. And then once you've observed a certain number of ketamine sedations, you're then allowed to start practicing in a supervised capacity and gaining experience and exposure for your logbook to then start working towards being signed off for sedation. So it's a really nice complete package that sort of gradually builds up and allows you to gain experience and exposure to these medicines before you're ultimately signed off and allowed to do these sedations autonomously. And I think that's really, really important because, as we're already realizing, this is not a benign procedure and there's definitely some issues around it that we need to be really aware of.
So I think we'll wrap up the overview then at this point, but essentially just to reiterate some of the messages from it. So sedation is a pharmacologically induced altered level of consciousness, which has a huge potential to really improve and facilitate some of the care that we're giving to our patients that are presenting to us. What we've mentioned is the fact that this sedation can look very different depending on the agent with which you're using and the depth to which you're achieving sedation. That from someone being a little bit more relaxed to somebody being not too far away from a general anaesthetic. And with that range comes a number of complications that we need to be aware about, and we need to make sure that our practice is really spot on to try and minimise the risk of any complications that our patients might be experiencing. We need to definitely be aware of the system within which we operate and training, and make sure that we're then fulfilling that package of training. And then even when signed off, then make sure that we're reflecting on our practice and again, continue to fine tune it for the best interests of our patients.